Now I introduce my dear colleague, Professor Dalia Hassan. She will talk about audiological services during COVID-19.
Good morning, my dear colleagues and professors. First of all, I'd like to thank you, Dr. Ahmed, and the whole NHAR team and the ENT Clinic team for giving me such an experience and sharing very few notes about the Audiology Clinic in the ENT Audiology Clinic in the ENT Clinic Center. I'd like to start my talk by the last event yesterday, which is the ENT Clinic tart. It was a very nice tart, big, white, with many fruits over it, and sweetie, of course. And this is the result of 15 years of work. 15 years of work in the audiology. I'm going to talk about the Audiology Clinic. Of course, my dear colleague, Dr. Ahmed, elaborated all about the ENT, the surgical point. I will try to summarize very few points about our Audiology Clinic. Yes, it was a nice start, and it's after 15 years of heavy work. The ENT clinic, the Audiology Clinic, started by 3 personnel. Actually, 2 of them still here, myself, alhamdulillah, and Dr. Noah Hosni. Unfortunately, she's not here today with us. Started with 3 personnel, and now, mashallah, the number is rising, I think, up to 22, and we are waiting for more and more. And 2 important points for such group: الإخلاص والأمانة. الحقيقة كل اللي بيكمل معانا المستين دول موجودين فيهم، وده اللي إن شاء الله نكمل بيه على طول. Of course, we started, it was a long way. At the start, 1 patient, we are waiting for a patient, and even we were at home waiting for the call from the call center for us to go and do the assessment. Now the number is increasing and increasing with large number of centers all over Egypt, inshallah. And 2 main obstacles or 2 main events were facing the ENT clinic. The first event in 2011 وده كانت أيام الثورة، وإزاي قدر المركز، لأن احنا بدأنا 2008 و2008 كان الشغل قليل، بدأ يزيد 2009. لما بدأ الحمد لله يشتغل 2009 2010 جت الثورة، الشغل هدي تاني، فكنا محتاجين السيفتي وميجرز كتير الحمد لله وعدينا بيها. The second big event we are facing as a part of the general and worldwide with the COVID. What about the COVID and the ENT clinic? What we did? I'm going to summarize audiologic services during the COVID-19 pandemic. The following points will be highlighted: the concept of delivering audiology services, the guidelines related, the situations in Egypt, the telemedicine, teleaudiology, and closing remarks. Hearing healthcare is an essential service, at least for some patient groups and some interventions. Because hearing is important, audiologic services were important during the pandemic. For these services to continue, rapid and broad actions were mandatory to reduce the transmission of COVID-19. The importance of hearing and keeping clinicians healthy cannot be overestimated. It was mandatory that the staff feeling safe, the patients will either feel in the clinic is safe enough to visit, or that remote treatment may be an option. By rigorously following safety guidelines, essential hearing health care were safely delivered to patients during that period. The main concept in delivering the audiologic services during the pandemic was elaborated by the independent hearing healthcare professionals, the British Academy, British Society. They highlighted that during the pandemic, all were called to stop routine face-to-face services. And where services can be adapted and delivered remotely, this should be the preferred choice. Of course, audiology and the audiological services, we need to communicate with the patient, we need to visualize with lip reading, we need to be in close contact, so that's why it was one of the challenges. The guidelines and recommendations for such audiological service were described by the ASHA and another guidelines for provision of audiologic services. The third guidelines, another ASHA guidelines that were mentioned at that time. The guidelines for the ASHA, the first guidelines, were directed to use disposable items as even any clinic, to consider requiring the use of masks for all patients and clients, to change the foam covering or barriers over the microphones, and to consider the use of video otoscopy for allowing physical distancing during examination. Follow best practices disinfecting the audiology equipment. These were the guidelines by the ASHA. The recommendations for provision by that reference was directed to the employee, to the patient flow optimization, the personal protective equipment, room ventilation and disinfection, and of course modification to audiological procedures. In brief, the employee should receive regular PCR testing, face masks, disinfect hands. Patient flow optimization, no accompanying people are allowed for adult patients. One accompanying adult is allowed for each child, and all patients and visitors should be screened upon arrival using a COVID-19 checklist. Patients may only enter in a special entrance, design entrance. For the personal protective equipment, the masks, but it was very important to know that the mask lead to 12 dB hearing loss change at the SRT. Clinicians should wear gloves and extra gown. A transparent face shield was one of the options to enable lip reading. Hand sanitizer should be available in multiple places. As regards the room ventilation, the rooms should be well ventilated, and the maximum duration in the sound booth should be 15 minutes. The rooms should be sufficiently ventilated every 15 minutes also, and to use only needed instrument and to avoid and remove all unnecessary equipments. The room ventilation also using the ethylene oxide. These were the recommendations for at least 10 minutes sanitization, and all equipment that comes into direct contact with the patient should be sterilized with alcohol wipes. Modification to audiological procedures. To give instructions via headphones, insert phones, or via lip reading across a screen. Before testing, the patient should be given printed instructions to decrease the time with exposure with the patients. Recording OA and ABR in using a single-use tissue sheet should be placed over the couch. And for the first fitting and activation of cochlear implant processor, the patient should be sent instructions and guidelines before the appointment. The second or the third guidelines by the ASHA, these guidelines considered every audiological equipment. For example, I'm giving just examples. The audiometer should be disinfected in particular way with specific recommendations. Also the real ear measurements and the tympano and the VNG and all other equipments. What about Egypt? These were the international guidelines. What about Egypt, and what's the situation? Did we respect this? Did we try to do this or no? Actually, on the governmental level, if you look to governmental hospitals as regards the audiology clinic or the audiology unit at Shams University, closure of the units was done many times during that period. Reduction of the number of the working staff and alternating days work, the reduction of number of patients per day, cleaning and all PEE measures mentioned was respected as much as we can, and vaccination of all staff. Okay, what about the private level? Private level, one of the best examples in dealing with the COVID and audiologic service during COVID was the ENT Clinic Center. They respected, or we respected, all the rules using the protective device, the facial masks, frequent sanitization, otoscopic video otoscopy during examination, hand sanitization, and even if we have a patient in the audiology clinic presented with COVID, the clinic stop and a perfect sterilization for all equipments, for all staff before the second patient enter. Waiting areas were spaced, not all the patients sitting with each other. Another option that the patients stay outside even in their car, and we give them a call at time of their assessment. These were the general measures, and these were the specific audiological measures actually done in the audiology clinic during the pandemic. Well, alhamdulillah, we are still keeping doing this till now and forever, because we don't know. There are variants, and we should respect this as much as we can. What about the teleaudiology during the COVID pandemic? Telehealth aims to provide healthcare services to underserved population across the world using communication in IT. The word telehealth means healthcare at a distance. Advanced technology and connectivity have helped in bridging the gap between patients, thereby overcoming the economic and geographical barriers. It has also enabled better access to professional training resources and mentoring for the healthcare professionals. The patient is either at home or in a visit in a nearby satellite center. These are the AAA and the ASHA describing and prescribing the alternative low or no touch mode in delivering audiological services. To summarize the difference between conventional clinic, high touch with patient-doctor relationship or direct contact versus low or no touch, the conventional clinic mainly for diagnostic purposes versus the alternative for hearing aid fitting and cochlear implant. Test environment is different. Of course, this needs sound-treated room, the other either in home, high risk versus low risk. And also this is an example for the no touch, all by calls. Even the hearing aid or the cochlear implant can reach the patient through mailing, and the communication through telehealth. This is the low touch. The patient and the audiologist, they meet at a time, but the remaining steps through telehealth. These are the audiological services that can be delivered through teleaudiology, hearing loss identification. Even they designed specific equipments that patient can take it at home, and by communication through online, we can know the hearing levels of the patient. Hearing aids related services, cochlear implants, tinnitus, auditory training. What about Egypt? At the governmental level, Ain Shams University, but I missed I don't know where the slide for the ENT Clinic, Telehealth, mainly was directed for the hearing aid fitting and following up of the patients. The patient receive a hearing aid at home. One of the dealers for a Nahar company go to him at home to adjust if the adjustment done at the clinic at that time was not that good, and follow up by phone for all the services. But the audiological diagnosis was kept at the clinic. The governmental level for telehealth was by the COVID-19 screening questionnaire for audiovestibular symptoms in Arabic language. It was developed, standardized, and validated at Ain Shams University, and actually it was a part of master thesis at the clinic, at the unit. This is the questionnaire. The questionnaire was done and was applied on 1,015 adult subjects with a mean age 33.8. 85 or 86 of the subjects received it through web-based media facilities, and the remaining were at the clinic. And by collecting the questionnaires only, it was proved that 37 of the patients with COVID complained of dizziness, and this will be highlighted by my colleague, Dr. Taysir, now, about what's the vestibular system in the COVID. And 52% of subjects with COVID got audiovestibular manifestations. And interestingly, it should appear in the first 15 days with a maximum 60 days period, upper limit. Risk factors: females, recurrent infections, anosmia, migraine, chest disorders, previous history of ear complaints are all risk factors to get audiovestibular affection in those with COVID. Closing remarks. COVID-19 crisis is a serious moment. While the threat is very real, it offers a unique opportunity to redefine and innovate how audiologists reach and serve patients in more responsive, efficient, and person-centered ways. For the sake of patients and the continuation of profession under current circumstances, changes are absolutely necessary. Please, mouth masks are the new normal sanitary measures at the audiology clinic from now and on. Thank you very much.
Thank you, Dr. Dalia. I think it was a very tough days at that time, but I need to say that precautions must be taken up till now, because we are not safe in these times. Okay, thank you.